Hello, it's Dr. Ominde here. So just to finish the series on the arm, we had just talked about the course of radial nerve, and we were to talk about the clinical relevance. So radial nerve palsy. What is radial nerve palsy? Radial nerve palsy is injury to radial nerve caused by different things. It could be fracture at the midshaft where you have the radial groove. You can get it through intermuscular injections or Saturday night palsy as you sit with your arm on the chair for a long time, the chair compressing the radial groove. It can bring to Saturday night palsy. And then there's crutch paralysis. The people who use crutches because of lower limb issues, crutches can compress the radial nerve. And you also have midshaft fractures of the humerus. So this can result to the loss of function of the extensors of the forearm. Remember, the extensors are in the posterior compartment of the forearm. So if radial nerve is injured, the extensors cannot work, so they cannot extend the wrist. So you have unopposed flexion at the wrist because the flexors are now acting unopposed. The extensors are not working. So you get what we call wrist drop. Okay, and there will be an element of also weakness in the adduction and abduction of the hand, but commonly the abduction because the muscles in the extensor compartment, like extensor carpi radialis, longus, and brevis, they cause radial deviation at the wrist. So these are arrangements of the nerves in the cubital fossa. Behind the medial epicondyle, you have the ulnar nerve. Passing through the cubital fossa, you have your median nerve, and on the lateral aspects, you have your radial nerve that's dividing into the deep and the superficial branches. So this is your biceps brachii muscle, and this is your cephalic vein here. Okay, then this is deltoid here. This is your triceps and your brachioradialis on the lower aspect. So briefly on the cubital fossa is the space on the anterior aspect of the elbow joint, and it's usually as the boundaries. On the lateral aspect, you have the medial border of brachioradialis on the lateral aspect, and then the medial aspect, you have your lateral border of pronator teres. So lateral border, you have medial boundary or medial border of brachioradialis, then medial border, you have the lateral border of pronator teres. The base of this cubital fossa is formed by an imaginary line that will connect the medial to the lateral epicondyle. So it's like a triangular space. So laterally, medial border of brachioradialis, medially, lateral border of pronator teres, and the base is by an imaginary line that is connecting the lateral and the medial epicondyles. So the apex is where the two overlap. So where you have pronator teres and brachioradialis overlapping. So that forms the apex of your cubital fossa. So which structures are in the roof of the cubital fossa? The skin, below the skin, superficial fascia, then the deep fascia, and then you have your bicipital aponeurosis. Okay, then the cephalic vein on the lateral aspect, basilic on the medial aspect, and these are joined by the median cubital vein that is connecting the two of them. And again, at the cubital fossa, you have your lateral and medial cutaneous nerves of the forearm. So as you can see here, the lateral cutaneous of forearm from musculocutaneous and medial cutaneous of the forearm. So these are the contents of the cubital fossa, the deep contents. So from medial to lateral is usually the bicipital, or rather the biceps tendon, followed by brachial vessels, then the median nerve. So that's the order from medial aspect to lateral aspect, the deep contents of the cubital fossa. So biceps tendon, brachial vessels, and the median nerve. So your biceps tendon, brachial vessels, and the median nerve from medial to lateral. And this is your median nerve, this is the brachial vessels, this is your biceps tendon, so medial to lateral. So what is the applied anatomy of the fossa? Remember, we also have the nerve is occurring also in the fossa. So you have median, and the biceps tendon is the most medial. So the applied aspect of the cubital fossa, we have the median cubital vein, okay, and it's usually the vein of choice. It's a superficial vein of choice for intravenous injection and venipuncture. So osteology of the arm, there's a humerus that has head, anatomical neck. Okay, this is the surgical neck of the humerus. This is the greater tubercle, the lesser tubercle. Remember, the greater tubercle, you have the supraspinatus, infraspinatus, and teres minor, and the lesser tubercle, you have subscapularis inserting there. That's your anatomical neck, that's the head. The surgical neck has axillary artery and the circumflex humeral vessels going around it. This is your intertubercular groove containing biceps, long head of biceps tendon. Okay, and within the bicipital groove, we also have latissimus dorsi inserting there. This is your lateral lip of the bicipital groove where pectoralis major inserts, medial lip where teres major inserts. This is your medial epicondyle. Posterior to it, what do you find? Ulnar nerve. And this is your trochlea articulating with the trochlear notch of ulna, capitulum articulating with the head of the radius. Above the capitulum, you have your radial fossa. Above the trochlea, you have your coronoid fossa. This is your lateral epicondyle. These are your supracondylar ridges. This is deltoid tuberosity for deltoid muscle. And this is your radial groove where you find radial nerve and profunda brachii artery. So we have, this is a head, this is your anatomical neck and the surgical neck. So we have what you call the angle of inclination, that is usually between the axis of the head and the axis of the shaft, and it's 130 to 150 degrees. And then we also have what you call the angle of torsion, the sort of tilting of the humerus posteriorly and by 30 degrees. So that's angle of torsion of humerus. Normal is 30 degrees posteriorly, and angle of inclination is 130 to 150 degrees. So applied anatomy of the arm, you have biceps tendinitis, inflammation of the biceps tendon. You have rupture of the tendon of long head of biceps that can occur. There could be dislocation of the tendon of the long head of biceps. And the median nerve can be compressed by Struthers ligament formed by the persistence of third head of coracobrachialis. You can have medial epicondylitis like in golfer's elbow where repetitive use of flexors of the forearm. Then you have lateral epicondylitis in tennis elbow where you use the extensor muscles of the wrist, like in tennis elbow. Rotator cuff tear, supraspinatus, infraspinatus, teres minor, and subscapularis. When you have tear, it affects the stability of the glenohumeral joint. You could also have avulsion fracture of the epicondyles where you have origins of flexors on the medial epicondyle and origins of the extensors on the lateral epicondyle. So when the muscles pull, you can get the avulsion. So another aspect of applied anatomy, you have humeral fractures. If you fracture the midshaft, you affect radial nerve leading to wrist. Surgical neck, you affect axillary nerve, and abduction will be affected because deltoid is affected and you lose sensation in the bulge region. Supracondylar fractures, the median nerve can be affected as the cubital fossa. Then the medial, remember posterior to it is the ulnar nerve, so it can be affected. So thank you very much.